Welcome to Advance with MUSC Health. I'm your host, Erin Spain. This show's mission is to help you find ways to preserve and optimize your health and get the care you need to live well. Today's guest has spent more than 4 decades in the field of hematology oncology, helping hundreds of women facing a breast cancer diagnosis. Dr. Stephen Akman joins me today to talk about the importance of breast cancer screening, how to assess your breast cancer risk, and current approaches to breast cancer treatment. Welcome to the show.
Thanks for having me.
Tell me a little bit about your background. Now, as I mentioned, you've been practicing for more than 43 years with a focus on treating breast cancer, but I'm curious, what led you to this specialty?
Breast cancer is obviously a highly impactful cancer. It affects so many women plus families. And the other thing is it's a cancer that's highly treatable and in many cases, I would say most cases, curable. So you get to help people with a kind of realistic opportunity for a really good outcome.
Now, I heard a rumor that you came out of retirement recently to continue your career in treating women with breast cancer. Tell me a little bit about this decision.
Well, yes. So I had retired at age 70 several years ago, but I just missed seeing patients. That's what I like to do. And this is a good balance for me. I see patients and yet I'm part-time retired.
Let's start with a topic that's essential in the fight against breast cancer, and that is screening. As you mentioned, if it's caught early, this is a highly treatable cancer. Can you explain a little more to me about that? Why is screening so critical in the fight against breast cancer?
It's clear, even with modern treatment, that the lower the stage, what we call the stage of the cancer, which means how big is the cancer, how much has it spread at the time of initial diagnosis, the lower the stage, the better the outcome. And the modern screening tests, mammography, particularly the newer tomographic mammography, plus ultrasound, plus MRI, are in general much more sensitive than our fingers are. And then before symptoms are manifest. So the opportunity to catch cancers at lower stage is the result of screening. In fact, when I first started in this business, only about 30% of patients were identified at stage 1. Now it's much more than 50%. So the data are pretty clear that breast cancer mortality, death from breast cancer, has been declining since the mid-1990s steadily by about 1% to 2% per year. Some of it can be attributed to better treatments, but the majority of that can be attributed to better screening.
And while the screening is better, there is still some confusion out there about how often or when women should be screened. Can you tell me about the recommendations and what you tell your patients?
Yes. So there are 7 or 8 organizations that are giving recommendations about screening. And the confusion arises. Number one is what endpoint, what outcome is that particular organization looking for? And how do they look at the data? All but one of those screening organizations recommend annual screening beginning at age 40 to 45. So the American College of Radiology, the American College of Obstetrics and Gynecology, and so forth, the American Society of Breast Surgeons, all recommend annual screening. In Europe, the National Health Service in England will pay for mammography annually beginning at age 45, but they stop at age 73. So there's some debate, even in this country, about how long women should continue screening. But in that age frame, all but one of the United States organizations would say annual screening.
So your recommendation as well to patients then is to start around age 40 every year?
That's right. I also go with the majority of organizations stating annual screening.
And of course, there are some situations where there are women who are at higher risk of developing breast cancer earlier in life, earlier than age 40. Tell me about those patients and how you counsel them.
So there's sort of primary and secondary risk factors, and there are good risk models based on those factors, computer models that can predict how does an individual woman's risk of developing breast cancer in their lifetime or within a defined period of time compare to an average woman who doesn't have those risk factors. Now, I emphasize that all women, being a woman is a risk factor. 1 in 8 women in their lifetime will get breast cancer in this country. So these models predict those who are at greater than average risk. And the kinds of factors that they use are, number one, family history. Is there breast cancer in the family, particularly women or men who have developed breast cancer at a young age, under the age of 50? Other factors include age of onset of menses, how many pregnancies or no pregnancies, when was the first pregnancy, what does the breast tissue look like on screening? Is it dense on a mammogram or not? Did that person have prolonged use of what's called hormone replacement therapy, combination estrogen, progestin pills? Or did they have a biopsy previously that showed not cancer, but something, a lesion like atypical ductal hyperplasia, atypical lobular hyperplasia, flat radial scar, something called PEA, that are predictors that there's something not quite right with the breast. So all those things fit into the models. Now, generally, if there is not a family history of breast cancer at a very early age, we would still recommend screening at age 40, but we might recommend high-risk screening, which is a little bit different than annual mammography. If a woman has a close family relative, sibling, parent who had breast cancer under the age of 40, we would typically recommend starting screening at least 5 years before the age of the relative.
And there's also genetic screening nowadays that can tell you if you have a genetic mutation.
That's right. There are guidelines that providers and patients can look at. There's an organization called the NCCN, National Comprehensive Cancer Network, that publishes these guidelines. And they actually have a website for patients that will tell us what are the criteria to suggest that there's a high enough chance that an inherited breast cancer associated genetic mutation occurred that we would recommend screening. And generally, those guidelines use factors that would say there's more than 10% likelihood that the test is going to be positive.
You were mentioning that there's computer models that do this assessment score. This has actually been in the news a little bit lately. There was an actress, Olivia Munn, who said that her doctor did a breast cancer risk assessment score that led to the high-risk screening that caught breast cancer that could have otherwise not been detected. Is this something that women can do at home? Are they able to calculate their own risk score at home?
So the models, the Tyrer-Cuzick model is the kind of the most prominent one these days. They are available on the web, but this is a kind of thing that I would not recommend a person doing at home. I would recommend them doing it with their provider so they can better understand what the risk is actually saying, because one can extrapolate from those risk models things that are not intended to be extrapolated by the models. For example, if the model would predict a higher than average risk, some patients extrapolate, mean that they're at very high risk to get breast cancer. That's not what the model's saying. What it's saying is that you're higher than average risk. That's all it's saying. So again, I encourage women to do it with their providers.
Let's talk about treatment. Breast cancer treatments typically involve a combination of surgery, radiation therapy, chemotherapy, and possibly hormone therapy. Tell me about the current approach to treating breast cancer and how you design the best treatment plan for each patient.
Yes, so you're absolutely right. And I tell patients that one of the reasons that patients do better than they ever have before is because, number one, there are a number of different providers with different areas of expertise on their team. And breast cancer is a team treatment approach. Number two, there are a number of different modalities to treat breast cancer. So I say there's a number of different tools in the treatment toolbox. Now, I roughly divide those tools into two groups. One group is what we would call local treatments. Surgery is an example of a local treatment. It is a very good treatment for breast cancer, but it's only good where the surgeon puts his or her knife. The second modality that's a local treatment is radiation. Radiation is a very good treatment for breast cancer, but it's only good where the beam is directed. So the other bucket would be systemic or whole body treatments, which is what we medical oncologists use to treat cancer wherever it might be in the body. These are medicines that get in the bloodstream. And again, they come in different flavors. Chemotherapy is one. Those are medicines that are designed to get into the bloodstream, find cancer cells, and kill them. The second modality is, as you mentioned, hormone therapy, which is designed to manipulate the hormone estrogen in the blood, which is the gasoline that fuels about 75% of all breast cancers. The third group is what we would call targeted therapy, where cancer cells have a specific protein on their surface that we can direct target treatments that seek out those. And the fourth these days, in a small subset of breast cancers, is immunotherapy, which doesn't attack the cancer directly. What immunotherapy does is takes the brakes off the body's own immune system to attack the cancer. There's a subset of breast cancers called triple negative, which means they're not under the control of the hormone estrogen, and they don't have a target on their protein. That's only about 15% of all breast cancers, but there's good clinical trial data that those patients may benefit from immunotherapy.
And how do you assess a plan for each of these patients? When might you not do radiation or chemotherapy and just do surgery, for example?
Anytime a cancer doctor would make a recommendation to a patient, we like to be guided by research, by clinical research, by evidence that says this is the right thing to do. And there's now 50 or 60 years worth of clinical research to back up those decisions. So the treatment decisions, which modalities we're going to use, depend upon several things. One we call clinical factors, which would include the size of the lump when it's first presented. Has the cancer spread to lymph glands under the arm? What does it look like under the microscope? Is it under the control of the hormone estrogen? Then more recently, we have what's called genomic tests that interrogate the individual biology of a patient's cancer, like the Oncotype DX test or the MammaPrint test, and there are several others. Those are the two most prominent. All those help us decide what's the best treatment for an individual patient, plus the use, when it's appropriate, of screening scans, CT scans, bone scans, or PET scans. They're only appropriate under certain circumstances, but they're part of the decision-making process.
I want to shift gears a little bit. Many of your patients live in rural areas. You split your time between MUSC Hollings Cancer Center and more rural areas of the state, such as the Hampton Regional Medical Center. Tell me about some of the challenges patients might face when assessing screening and care if they live in a rural area.
Fortunately, screening for people who are motivated and who are medically educated, screening is really available to almost everyone. One of the issues in our area is that people are not as well medically educated, particularly our underserved population, as we would hope they would be, and that's a challenge. Second challenge is logistical. Transportation is often an issue for a number of our patients. Financial stresses are an issue for a number of our patients, rural patients, particularly those that are either underserved or retired and living on Social Security or those sorts of situations. It's not uncommon, not only for breast cancer, but for many other cancers, for patients to present at a more advanced stage out in a rural community than they would if they were in a sophisticated urban environment.
How does MUSC Health help address that issue? I know that now they're opening up more services into the rural areas.
Yes, so in several ways. One, by directly sending providers like me. Number two, by providing direct telehealth services to patients or consultative services from primary care providers out there to MUSC experts. In our own specialty, we have set up, with the help of MUSC, a chemotherapy infusion at Hampton Regional. So patients don't have to travel for chemotherapy. That's one of the most gratifying things that we've done. So patients who need treatment can get treatment out there. Now, we don't have radiation facility out there, so they need to travel to a center for radiation, but at least chemotherapy we can give without them having to travel great distances.
And they also have access to the clinical trial network that's available through MUSC Health. Tell me the benefit that could be to a patient.
We encourage, of course, every patient who's eligible for a clinical trial to consider participation. Not only are we helping the next generation of patients, but they may provide access to some treatments that are not available under standard of care.
You mentioned how important it is to empower your patients with educational support. Tell me about that. Why do you believe patient education is so essential for effective treatment?
Because patients can be their own advocates, not only in the screening portion, but in the treatment portion. I have a much more detailed and informative conversation with patients who are educated and want to be educated. But on the screening side, of course, getting that message through the importance of screening is an educational process.
And that's something that you're dedicated to doing, though, in each patient that comes through the door, giving them all the information needed. As you look to the future on the horizon of hematology and oncology, what's the most promising thing for the future of care, especially when it comes to treating breast cancer? What's next?
Of course, development of new treatments. It's relatively easy to obtain now an understanding of an individual patient's cancer targets. And pharma and the research community is working hard to develop treatments for each target. So that's one area. Improvements in immunotherapy is a second area. And then there are all these technological improvements that come along with radiation and surgery. I think we're going to see treatments that are safer, less toxic. So along with developing newer effective treatments, we want to dial down as best we can the toxicity of the extant treatments.
So exciting things on the horizon. As we wrap up today, what advice would you like to leave listeners with that they could share with a loved one or that they should take to heart themselves when it comes to screening for breast cancer?
Screening works. Now, with the modern screening and digital mammography and so forth, and MRI, patients have a much better statistical outcome. So it's important, and it's easy to say, well, I'll get it next year. But the idea is knowledge is power.
Thank you so much for your time and expertise today. You bring so much to the Hollings Cancer Center and all of your experience. So we thank you for your insight today.
Thanks for having me.
For more information on this podcast, check out advance.muschealth.org.